In this module, we turn our attention to social inequality. We'll start by looking at social inequality from 30,000 feet. Then we will take a look at how social inequality manifests in our global system, the effects that it has. Then we'll turn our attention to social inequality in the United States. And as we descend, we'll look at healthcare disparities as they become acutely manifest during the time of the coronavirus and COVID-19. We begin with this long quote from a recent book by the contemporary French philosopher Alain Badiou, The True Life. Today, 10% of the world population own 86% of the available capital. 1% own 46% of that capital. And 50% of the world own exactly nothing, 0%. It is easy to see why the 10% who own practically everything don't want to be lumped together with those who have nothing, or even with the less prosperous of those who share between them the scant remaining 14%. What's more, many of those who share that 14% are very roughly split between passive resentment and a ferocious desire to hold on to what they've got, in particular by the support they give, with racism and nationalism playing their parts, to the countless repressive barriers against the terrible threat they perceive in the 50% who have nothing. In our first module, Dr. Flourish presented a framework for critical social work. The first element in that framework was identification of the problem. The second was identifying the cause or sources of the problem. The third was to pass a negative judgment. And the fourth, finally, was to remove or favor removal of the offending causes. A truly critical social work involves all of these steps, and it is almost impossible to imagine not passing through each of these steps. The first challenge we have is to identify the problem. Not everyone can agree that the problems are rooted, for example, in the marketplace when we're trying to explain extreme social inequality. Some people would argue that the market, rather than being the problem, is the solution. But not everyone easily agrees on identification of what the problems are. Equally significant and sometimes troubling is identifying the sources or causes of the problem. If we imagine that it's very difficult for us to agree on the problem, that is, that which we're trying to explain and thus affect in social life, it must be equally difficult then to understand how we remove the source of the problem. If we can't agree, for example, that the marketplace in healthcare resources has been a tremendous problem in our current COVID-19 coronavirus crisis, then we will not attempt to change it. We'll go on imagining, believing that the market is the solution to the problem rather than the problem itself. The third element, which is to pass a negative judgment, if we decide that the market and the marketplace distribution of healthcare resources has been one of the most important problems or offending causes, then we must pass a negative judgment on it. In other words, the market is a problem, and we then make a judgment about the nature of that problem. And finally, then, we argue that it would be necessary to remove the offending cause. If the market is the cause of the problem, as many would argue has been with the current COVID-19 crisis, in the private market in healthcare resources, then we would have to address the market as a offending cause and then attempt to remove it as a cause or to change it in such fundamental ways that we never have the kinds of problems that we've seen in recent weeks and months with the COVID-19 crisis. The fact that there is extreme inequality is not in doubt. How to explain it, how to change it, there's very little agreement on. We want to share with you this recent report by Oxfam, Even It Up. This will be posted as a PDF on the Canvas website. We invite you to look at it carefully. As we said in our introductory comments, we want to start this module with a view from 30,000 feet, and then we'll be taking a closer look at how health disparity in the context of the COVID-19 coronavirus pandemic is manifest in the United States, even among healthcare workers. Just a quick look at this report, then we'll show you the details of some of their findings momentarily. Note first the endorsements by some very important people. Kofi Annan, the former General Secretary of the United Nations, and Professor Joseph Stiglitz, a Nobel Prize-winning economist. In fact, it is worth quoting him here in his endorsement. The extreme inequalities in incomes and assets we see in much of the world today harm our economies, our societies, and undermines our politics. While we should all worry about this, it is of course the poorest who suffer most, experience not just vastly unequal outcomes in their lives, but vastly unequal opportunities. 2. Oxfam's report is a timely reminder that any real effort to end poverty has to confront the public policy choices that create and sustain inequality. Again, we invite you to take a careful look at this report. We ask that you do so, and there will be some discussion questions that result from your consideration of this. This becomes especially important when we begin to look at disparities in healthcare and healthcare outcomes as it relates to the coronavirus. You will find on the Canvas website this excerpt from the Oxfam report, which gives you the view from 30,000 feet. Please take a careful look at it. 2017, the French economist Thomas Piketty wrote a book, Capital. It was soon followed up by a second book, Capital and Ideology. In the first of these books, Piketty sets the agenda to describe and explain the growth in economic inequality throughout the 20th century. Please take a look at the TED Talk. There's a link to the TED Talk on Canvas. It's a 20-minute TED Talk. We believe that you'll find it very informative and useful as we dig deeper into the sources of social inequality. There is no doubt that the current pandemic, the coronavirus and COVID-19, have revealed underlying problems in our market-based approach to distributing healthcare and healthcare resources in the United States and around the world. So next, we want to turn our attention to healthcare disparities here in the United States. Let's begin our discussion of healthcare disparities and the COVID-19 crisis by looking at some of the headlines in the major national newspapers that describe the extreme nature of the healthcare disparity as it is made apparent by the crisis and pandemic COVID-19 and the coronavirus. That health disparities are widespread is known to us. It is a problem. The source of the problem we'll have more to say about near the conclusion of this module. Sometimes a crisis like the pandemic and COVID-19, reveal underlying structures. So we'll take a brief look at the headlines here, just first of all to get a sense of extent of the crisis. Here you see a piece that appeared in the Los Angeles Times. 4 states, Louisiana, Michigan, Illinois, and North Carolina. So you get a sense of the disparity between blacks and whites, deaths per 100,000. There's a good piece that appeared in the New York Times also that deals with the tragedy that unfolded in Louisiana for Mardi Gras. We're going to put a link here on the resource page on Canvas where you can listen to a deeper, a podcast that describes this incident in Louisiana. The Washington Post reports April 7th, the coronavirus is infecting and killing Black Americans at an alarmingly high rate. Again, this is a comparison by state: Chicago and city, North Carolina, Louisiana, Illinois, Florida, Connecticut, Michigan, and D.C. So just a note here, in Milwaukee County, home to Wisconsin's largest city, African Americans account for about 70% of the dead, but just 26% of the population. In Louisiana, where 70% of the people who have died were black, African Americans make just 32% of the state's population. In Michigan, where the state's 845 reported deaths outrank all but New York's and New Jersey's, African Americans account for 33% of the cases. The Chicago Sun-Times writes in their headline, "Public Health Expert, a Marshall Plan needed to redress the coronavirus race disparities." The Marshall Plan was something that was initiated after World War II to try to rebuild Europe. But if you take a look at here as well, lengthy discussion of just how widespread the crisis is and various links to reports that describe it. The Robert Wood Johnson Foundation also did a report coping with the COVID-19 and a focus on health equity. There is a downloadable document there, which we'll have posted as well. The Miami Herald reports Black people in Miami die of COVID-19 at a greater rate than whites. Forbes magazine reports COVID-19 and health disparities and death. USA Today reports COVID-19 highlights racial disparities in our healthcare system. The Philadelphia Inquirer, Philadelphia officials worried about African Americans becoming more at risk for coronavirus. We're asking you to engage in a critical social work and to reflect on the elements required in a critical social work. First, that is to identify the problem. Second, to identify the source or cause of the problem. Fourth, to pass a negative judgment, that is to say that the problem is a bad problem. And fourth, that is to remove the offending cause of it. We're asking you to visit the Brookings Center website, where you will find a commentary, a detailed commentary with lots of links by Rayshawn Ray, a sociologist, a fellow at the Brookings Institute. We're wanting you to pay particular attention. In many ways, he's thinking about the structural conditions that cause racial disparity, as you see here in the subtitle. You will find here many links that he uses to begin to think about the structural conditions. So read this carefully. You'll be asked to reflect on this article in discussion and respond to it. We want you to take a break, grab a cup of coffee and some donuts, and listen to 2 podcasts, both done by a series called The Inquiry, the British Broadcasting Corporation. We'd like you to pay attention to this series, The Inquiry, because most of what they do has a direct relevance to social work research and social work practice. First podcast that we want you to listen to is What's Killing Black American Babies? Black infants are twice as likely to die in their first year as white infants. We then want you to pay close attention to the elements we have described as necessary to a critical social work practice. So as you listen to these 2 podcasts back to back, one done a little earlier and one done in the midst of the COVID crisis, we want you to begin thinking about the 4 elements. How do each of the experts who answer a single question, one, why are black babies dying at disproportionate rates? And the second, how is it that ethnic minorities are dying in the UK and US at disproportionate rates? Each of these podcasts ask 4 experts to address one question. Your task is to see in each of these podcasts how these experts identify the problem, identify the source or cause of the unmet needs, pass a negative judgment, and favor action to remove the sources of the problem. Do the experts have shared understandings of the problem, the sources of the problem, and valuations of the problem? Or do they have conflicting views? It is your task to do some connective thinking to sort out the complexity of different points of view. Now that you've finished your second cup of coffee, we want to turn our attention to the National Academy of Social Work website and the Grand Challenges, the 12 Grand Challenges proposed by the National Academy of Social Work. We'll spend a few minutes just introducing you to the project of the Grand Challenges and the National Academy of Social Work, but we want you to spend some time on your own getting familiar with the 12 challenges, the 12 Grand Challenges, paying particular attention to how the National Academy of Social Work has responded to the COVID-19 coronavirus crisis. We'll also ask you here to listen to the 90-minute webinar that was done in May of 2020 in the midst of the coronavirus crisis by 3 social work researchers and scholars. We're now on the homepage for the National Academy of Social Work Grand Challenges. For several years, the National Academy of Social Work debated and compiled a list of what they consider to be the 12 most important challenges for social work and the world that could be solved, that were feasible to be solved. And you'll see them listed here both at the bottom of this first page, but you'll also see them listed here. We would encourage you to look at the history of the National Academy of Social Work and how the Grand Challenges were formed. You'll see a link to that page which describes it here. I think it's very important for you to spend some time on that page looking at the history. For our purposes today, we're just wanting to introduce you to the 12 challenges, and if you could focus your energy for our purposes on closing the health gap and reading the paper that is associated with the health gap. It's not required that you read that paper, but it's pretty important that you take a look. Then there is also here to reduce extreme economic inequality. Purposes of our module today, those 2 grand challenges and the associated papers really are important for you to take a look at. For this module, it is our purpose to take a particular look at how the National Academy of Social Work has paid close attention to the COVID-19 coronavirus challenge. You do so by looking at the resource page and scrolling down to COVID-19 resources. And here on this page, you will find quite a range of responses that the National Academy and others in social work have made to the pandemic, including a webinar that we want you to listen to, be able to navigate your way to the webinar right here. This will be required of you, and there'll be some discussion and question. But you'll see here also that the other grand challenges have taken up the COVID crisis in different ways through the Ensure Healthy Development for All Youth group and looked at it. Healthy Relationships to End Violence has also taken a look at it. The Advanced Long and Productive Lives has taken a look at it. To eradicate social isolation, to end homelessness. So you'll see that each of the grand challenges have attempted to look at the COVID crisis and put it in the context of the grand challenges. So just to remind you, you are required to listen to the webinar that was done just a few weeks ago in response to the COVID-19 crisis. On April 20th, the governor of New York, Governor Cuomo, described the condition of the frontline worker in New York City and state.
And if you look at who they are and the equity and fairness of what has happened, I think any reasonable person would say we should right this wrong. 40% of the frontline workers are people of color. 45% in public transit, 57% of the building workers, 40% of the healthcare workers. People of color are also disproportionately represented in delivery services and child care services, right? The economy closed down. The economy did not close down. It closed down for those people who frankly have the luxury of staying at home. All those essential workers who had to get up every morning to put food on the shelves and go to the hospitals to provide health care under extraordinary circumstances, and the police officer who had to go out to keep you safe, and the firefighter who still had to go out and fight the fire. Those people worked, and they went out there and they exposed themselves to the virus. 2/3 of those frontline workers are women. 1/3 come from low-income households. So they've been doing this work. They've been stressed. They're going home to a household, often had 2 wage earners. One of them is now not working. They're living just on that one salary. And after all of that, we see the infection rate among African American and brown Americans higher proportionately than other groups. Why? Because they were out there exposing themselves. That's why. And you can talk about health disparities, etc. But I believe all the studies are going to wind up saying, yes, when you were home with your doors locked, dealing with cabin fever, they were out there dealing with the coronavirus.
No doubt, when we look back on the history of the coronavirus and the public health measures taken to curb the effects of it, all the ways that our politicians attempted to intervene or failed to intervene, we'll have much to say about their effectiveness or not. We just want to take a few minutes to introduce you to this report that was used by the governor of New York in what you just heard to talk about the frontline workers. We'll post this as a PDF on the Canvas website. We're not expecting you to read it or be accountable for the content of this report, but it is a good idea to get familiar with how the frontline workers are described by the state of New York's comptroller and the Bureau of Policy and Research. This is what the governor was using to talk about. And so you'll see here the breakdown of workers by gender in these various sectors of the New York economy. This is the New York City economy, and the share of New York City frontline workers who are foreign-born, the share of New York City frontline workers who are non-citizen, and where the frontline workers live, boroughs, the percentages of them that live in Queens and in Brooklyn and then where the city workers live, how our frontline workers get to work, the share of New York City frontline workers who are off-peak transit workers, some data on compensation. Then there's data on the frontline workers who have no health care coverage, and the share of frontline workers with children living in the home, the share of frontline workers who are over the age of 50. And then the report ends with some recommendations. So while we're not requiring you to read this report, we do think that it's important to look at it and get familiar with the kinds of data that social workers should be familiar with. In 2017, UCLA Labor Center joined with a couple of partners to produce this report, The Ready to Work Uprooting Inequity, Black Workers in Los Angeles County. We've been spending a lot of time in this module and the previous one talking about New Jersey and New York, so we thought it would be important to skip across the country and take a look at how the COVID crisis is affecting workers in disproportionate ways in California. And we'll focus today in this module in particular on Los Angeles County. This is a 52-page report, so this brief 30-minute module that we have with you, we're only just letting you know about the importance of this report and asking the question, why should we know about Black employment in Los Angeles County before the COVID crisis of 2020, 3 years later? Well, obvious reason is that if Black workers were suffering in 2017 from employment issues, then 2020 and March 2020 and beyond, the long-term effects of this pandemic are going to have considerable consequences for Black workers. So we want you to take a look at this report. It will be posted on the resource page in Canvas. We don't expect you to read the entire report, but we do want you to read this section of the report, Racism and Health, beginning on page 15. So it's a good idea still to just peruse the entire report to get a sense of labor studies found. In particular, it's probably a good idea to read the executive summary. In mid-May, the University of California, Berkeley Labor Center produced a report on the frontline essential jobs in California. We looked at this earlier in this module for the state of New York, and we have posted on the resource page on Canvas the larger report that was done describing the essential frontline workforce in New York City. Let's take a look at the University of California Labor Center report on frontline essential jobs in California. Notice first, as the COVID-19 pandemic continues to evolve in California, as they say here, there is growing concern about the essential workers who are still on the job coming into frequent contact with customers and other workers, increasing their likelihood of exposure to the virus. Recent articles, as they note here, have examined the increasing infection rate for workers, hospital, home care, nursing home, grocery stores, warehouses, meat processing plants, trucking, and public transit. You'll notice that when you looked at the New York City data from the state of New York, there's similar workforce characteristics. The analysts have been hypothesizing that greater workplace exposure might be contributing to higher infection and mortality among workers of color. So we want you to take a careful look at this data, race and ethnicity, and the essential workers in California, immigrant workers, the nativity of the frontline worker, percentage of workers employed in frontline essential jobs. There'll be a link on Canvas to this website so that you can get familiar with the data from California. We want to spend a few minutes talking to you about the pandemic and the ways in which the social service workforce around the globe faces special challenges. Social work and social work researchers are often concerned about the work conditions, and under this situation, that is the pandemic and the COVID-19 crisis, there are special challenges that workers face in these various global contexts. So we want to broaden our perspective in these few minutes and introduce you to this website, UNICEF for Every Child, and you will find on this website a report that has been done. There is a link here, a downloadable file that will introduce you to the kinds of questions and concerns that the UNICEF and their partners are addressing in this report. I'm going to just quickly preview of it here, but ask you to go on to the website and download it for yourselves. You'll see here, first of all, their partners, and then the report tries to identify what the key issues are this moment of crisis for social service workers around the world. Again, we invite you to take a careful look at this brief report.
On the first part of this module, we've been talking about health disparities and the way in which COVID-19 exposed structural elements of why we have such health disparities in the United States. Oftentimes, that's what a crisis does. It pulls back curtains and we can see inside because it's the routinized and regularized way that we go about healthcare in this country is somewhat hidden from us. But when there's a crisis, you can see in, and that's exactly what's happened with COVID. Because as Dr. Longhofer has done in the first part of this module, he has demonstrated how in just 2 months, suddenly the media and the United States has become policy makers and legislators, and people are talking suddenly about health disparity. And they've always been here. So that's the evidence that crisis has exposed something. What it has exposed is something that has been there in terms of two things. First of all, there's access to healthcare and how one can, has symptoms. Do they have insurance? Can they go to the emergency room? But I don't think that in the end, access is the problem. It is part of the problem. But access cannot explain what we talked about in the first module and the second module around unequal exposure to the virus, which is really part of why there was a different outcome for so many people of color with COVID-19, both in who got ill and died and the frontline workers who had to expose themselves over and over again because that was the work that they did. So now that's a different problem than access to healthcare. Well, what do I mean by that? Well, let's go further into identifying the problem and identifying the cause. Personal protective equipment was needed, and it needed to be distributed to every person who was either a frontline worker or someone who was vulnerable because of underlying health issues that made them susceptible to the virus. Well, what happened when we can look back? Well, personal protective equipment was not organized, coordinated, and distributed in some kind of collective fashion. States, the one aspect of this crisis that just sticks in my mind over and over again, it is the tragedy of it all and the death and many of the horrible things that have happened. But alongside that has been the way in which states were put in competition to buy PPE from private manufacturers, and they all had to compete with each other to do that. That is a problem. And I would argue that the cause of that is the way in which healthcare is organized in this country as a private market-based system. It's been commodified in such a way that different healthcare systems compete with each other to get patients. They compete with each other for the best doctors, the best nurses. They compete over who has insurance and who doesn't have insurance. So let me give you a hypothetical to demonstrate my point. What if our healthcare systems weren't in competition when this crisis hit in New York City, for example, so that all the hospitals could suddenly get together collectively in a centralized way, in a collective way, decide, you know what, let's make one of our hospitals a COVID hospital immediately, keep all the other hospitals open for business and let them run as normal. Well, they couldn't do that. They're in competition with each other. There was no structure for them to collectively get together and make that kind of decision. That is the kind of decision that needed to be made. Same would be true, I would say, for nursing homes competing with each other. There's no centralized structure that they could all talk to each other, decide how they were going to distribute PPEs. And we'll learn when we talk to the Rutgers student who works in a nursing home that we're going to be interviewing in one of the subsequent modules. You'll learn what that was like for her on the front lines to wait in a hierarchy over how the PPEs would be distributed. So why were PPPs distributed in unequal ways? Because there's no collective distribution of it. There was no way that people could look to one system that would say, this is how we're going to take care of everybody. Why was everybody look out after themselves? Because the underlying problem was competition, a system that was set up to compete with each other in the healthcare system for patients. So if that's the cause, and that's an unwanted determination. Then you get to step 3 of a critical social work, which would be to then ask the question, how do you pass a negative judgment on that competition? And as you can imagine, at that stage, you can run into quite the debate, quite the controversy, because many in this country organized, I would call it the extreme market system. Competition is not only normal, it's sought after. It's the lifeblood of the system. If you don't have competition, you can't have society. I disagree with that as a fundamental assumption, but it is one that we have that's stimulated, we're raised in it, we're socialized in it because the market requires competition. Now, but I would argue that we should pass a negative judgment on competition as being the centralized motivator or mechanism by which healthcare systems relate to each other. It should not be around competition. So that would be the negative judgment I would pass. So the 4th step would be to come up with ways to get rid of competition so that there could be more of a collective enterprise when it comes to how the healthcare system is organized. And that's all the way from the top to the bottom. That is how we educate nurses and doctors, dentists and hygienists and everyone else who has to be in a hospital and in the healthcare system, all the workers. How they get trained. That should be a collective enterprise, not a competitive kind of system. And second, then, there would be more of a collective sense that what this is all about is not making profits off of people's illness, but what the mission of the healthcare system should be about is the collective healthy well-being of all of us. Now, that would be desirable to move in that direction. But this gets us to the sticky question, tension between desirable and feasible. So I laid out an argument that what would be desirable is to get rid of the unwanted competition in the healthcare system. But is it feasible? Could you just eliminate competition today? I don't think so. Our healthcare system is too organized around a for-profit capitalist system, the way hospitals are set up, the way hospital medical equipment gets produced, it's for profit, the pharmaceutical industry. There's so many different players in that system that if you just pulled the plug tomorrow and said we're not going to do it that way, it would create chaos. So eliminating competition is desirable, but doing it quickly would not be feasible. So how do we work with that tension? Well, you could just give up. You could say, well, if it's not feasible, then don't worry about it. Don't even try anything different. But that seems very nihilistic. That seems that only gives us only one alternative, and that is that there is no alternative. We just have to live with what we have. And I think that that is the swampy ground that social work exists in. I hope at least it does. That it exists in the swampy ground of imagining someplace in between desirable and feasible, that we can hold a vision, even though it's not yet feasible, and work toward and strive toward a better system, which would be a collective system organized around healthcare that's not competitive and not set up for profit.